TopMedTalk.
Nick Majerison here. From October the 8th to the 12th, it's all about Dingle on TopMedTalk. Evidence-based perioperative medicine, EBPOM, is proud to present the 21st current controversies in anesthesia and perioperative medicine and the SIAA Autumn Congress. Check out ebpom.org/meetings to find out more. Then, from October the 19th through to the 23rd, it's Anesthesiology 2019, the annual gathering of the American Society of Anesthesiologists in Orlando, Florida this year. TopMedTalk will be covering the conference from day one with live streaming of our conversations from the booth and unique content. Check out our website for more details, www.topmedtalk.com. That's www.topmedtalk.com.
Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk. It's Monty Mython here, Editor-in-Chief of TopMedTalk. I'm here with the US anchor, Desiree Chappell.
That's right. Hello, Monty.
And we're delighted to be joined by Dr. Dan Cole. Dan, welcome.
Thank you for inviting me.
Great. Dan's a local from UCLA, as I understand. He's an anesthesiologist in the UCLA Medical Center. Now, I'm from UCL, which is University College London. And often people say, oh, you mean UCLA? No, I said, no, University College London. You're from the University College in Los Angeles.
That's correct. But California is the important bit of it.
So you're used to looking out the window and seeing the waves crashing and the sun shining.
It's a lovely experience every day.
And I thought it did really never rained in Southern California. It rains, 2 weeks a year?
Well, we didn't want to disappoint our guests from London, did we? It does rain once in a while in London, doesn't it?
Well, moving on quickly. So Dan, amongst many other things, you're past president of the American Society of Anesthesiologists.
That's correct, 2016.
2006. And how long's the term for a president in the ASA?
1 year. You spend a year or two rising up through the ranks as first vice president, president-elect, so you're actively involved in setting the agenda for the ASA, but it's 1 year term.
And is there a tail with that as well? Do you have an immediate past president?
Immediate past president for a year, and then you are forever a past president.
And does that linger? Do you get Secret Service? And
I was just going to say.
Because we've got a past president coming later, I understand, to this meeting, but a different type of past president.
Yeah, he has the real Secret Service.
Yeah, that's right.
So you had to get yourself here. Secret Service didn't bring a limo around to correct you.
I came in a Southern California Classic, a Prius.
Yes.
Well, this, as I said, is the 7th annual World Patient Safety Summit. And one of the panels that's been added, I noticed sort of the 18th of these action items from the Patient Safety Summit is about delirium. And Dan, we know your name because it's often mentioned because we've been featuring on TopMedTalk the Brain Health Initiative, the ASA Perioperative Brain Health Initiative. And almost every time someone speaks about it, they say, wah, 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 Dan Cole, wah, 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 ASA. So tell us about the link. You kicked it off, didn't you?
Well, yeah. I mean, there's a lot of people that deserve credit for this, but I think, as you know, anesthesiology has a great heritage in patient safety. But I think as I was thinking about my agenda for my year as president, I wanted to think a little bit bigger than just preventing errors. Preventing errors is very, very important, but focusing on preventable harm, which I think is really kind of the transition that we've made in the last few years in patient safety, was a specific agenda. And we looked at several different areas that we might consider. And postoperative delirium, for a lot of reasons, became a very attractive patient safety target.
I mean, delirium, as we understand now more about it, I think we've always seen it and kind of said, oh, it'll pass, it's just one of those things that happened. We recognise delirium is possibly got long-term consequences. There is discussions about possibly the accelerated dementia, which we'll come back to in a second. There's also the recognition that we do many things that might promote delirium. We, I mean, as anaesthesia providers in particular. What do you think are the big ticket items that we can do something about next week?
Well, I think you need to think of postoperative delirium as something more than just the induction to emergence event. Mm-hmm. I think there are things that we can do in the preoperative clinic to screen for patients that are at high risk for delirium. There's some exciting potentials on the future where we may be able to genetically screen patients that have a risk for delirium, give them some things that they can do to make them strong for anesthesia and surgery. And then there clearly are best practices for the intraoperative and, almost more importantly, the postoperative period, in which you can probably prevent, and it's been cited that you can prevent about 40% of the cases of delirium that occur.
40%, well, that's a big opportunity. So can we walk through that sequence? On the screening bit of it, which was a recurring theme, the reinforced idea that we should look for the risk factors. The genetic screening is very, very exciting for the future, but next week, what could we do in our clinics if we're not doing it already?
Well, I think the easiest thing to do is to look for patients that are at high risk for delirium, the elderly being a very, very high-risk patient group. And you can do things like simply administering what's called the mini-cog exam, which is essentially asking or telling the patient 3 words, asking them to draw the face of a clock, and say, put it at 10:45. Put the hands on the clock at 10:45. After they've drawn the clock, then you ask them to repeat those 3 words, and you kind of get a test that's given in about a minute, and you get some sort of risk factor. Is this patient at high risk for postoperative delirium? So that's a quick way preoperatively to screen.
And a top result is within the minute they can recall the 3 words and they've drawn a perfect clock face with their hands in the right place.
That would be my goal if I were the patient.
I've seen Angela Bader do some presentations, Angela Bader from the Boston area, from some presentations in London to us, and she showed us some pictures of clock faces of people who'd come in looking as though by the eyeball test, they would look as you do today, Dan. They look extremely well, extremely healthy. And some of the clock faces that were drawn were just extraordinary. You know, the how far off the mark they were. I've not done that personally yet. Don't work in a world where I do the Preop Clinics. I'm at the other end, which we'll come back to. Have you seen it done, Desiree?
I have not, actually. In our PAT, in the clinic or the hospital where I'm working, it's one of the things that we were talking about, including in our pre-admission testing screenings, but we haven't done that yet. So, but I've kind of seen similar people that are doing it, similar outcomes with that.
As we socialise this, we could ask Mum and Dad to do it, couldn't we?
Yeah.
Ask the kids
absolutely.
to. Is it being socialised at all?
Absolutely. I mean, right now I think it's in a lot of preoperative clinics, and it's being used primarily in high-risk groups. A 25-year-old that comes in for a knee scope, you're not going to spend time doing that. And then it is out there in the literature and in the lay press that people hopefully understand that this is a way that they can talk to their primary care providers about their risk of cognitive dysfunction.
Right, so 3 words, clock face, get the hands in the right place, 3 words, recall. We'll play that game later, see how we get on. We'll try it again as the evening develops as well, see how we do at midnight. The next was this idea of getting fit for surgery. Now, is that physical fitness, mental fitness, or both?
Well, I think looking at the big picture, not just delirium, but a lot of these are indeed things that occur with delirium. People that exercise and have a lot of physical activity prior to surgery do better. People that have good nutrition prior to surgery, do better. With delirium, and there's not a lot of hard science out there, but there is some evidence, particularly with one of our collaborative partners, the AARP, that people that engage their mind, read books, play some of these mind games, can actually stay sharp for surgery. So those are some of the things that I would suggest.
And is there a suggestion you can build mental resilience? I mean, if you didn't do the crossword or the sudoku puzzle before, could you start 6 weeks before surgery, or is that a known unknown at the moment? It sounds appealing.
It's a known unknown. I think people that have higher executive function will do better and are at lower risk of postoperative delirium. How far that is developed within 6 weeks versus a lifetime, 20 or 30 years, is the unknown.
And then we get into... We're going to jump forward a little bit. We get into the operating room. Are there any simple things that we should be doing at the moment in the operating room that might make a difference?
Well, one of my hard and fast rules is that people over 60 do not get preoperative sedation, benzodiazepines, unless there is a critical need for it.
Yes.
And that plays into what I think is important is that there needs to be informed consent particularly for patients with high risk for delirium, about that, and they need to understand the risk of that preoperative sedation on their postoperative cognitive dysfunction. And so that is probably, I think, the number one rule, aside from doing a lot of the routine things that we take care of our patients intraoperatively.
Because that a milligram or two or more with some people of midazolam that correct in some practices to being completely normal, you can't have an anesthetic without it. That we're all learning to stop that.
That's my hard and fast rule.
And some, as we've heard on TopMedTalks, some of the preclinical studies that some of the delirium produced in susceptible animals goes on for days. It's extraordinary.
It's an amazing thing. And we in anesthesiology sometimes don't see that. I mean, we take care of them intraoperatively when they're asleep. We see them postoperatively when you can have emergence delirium.
Absolutely.
And we expect them to be hypoattentive, which is an aspect of delirium. And we aren't always there a day or two afterwards to see the impact of this disease.
Now, I work mainly now on a surgical intensive care unit, so I do see them, the ones who stay on the intensive care unit for days afterwards. So they're a very high-risk population because there's a lot going on. But I kind of get the impression that we're either seeing more delirium or we're recognising more delirium. And maybe part of that is we're recognising the hypoactive delirium as well that we didn't before. Is there any literature to suggest it's getting more common? I know we've got an ageing population, so...
Well, I would agree with you. I think, at least in America, we're seeing the gray tsunami, so to speak. And so we are...
This is I had this done particularly for this.
I recall I looked at Desiree when I said that.
There's a longer story.
Yeah, I was just going to say, it's all a facade, really.
But anyway, we're seeing that gray tsunami, and we've gotten better at taking care of sicker patients. And so we're doing more things to elderly patients, hopefully improving their quality of life. But the profile of delirium and what it means, your perioperative or your brain health, has become more important. And so indeed, I think you are correct that we're probably identifying it, particularly the hypoattentive delirium. When I grew up in anesthesiology in the 80s, delirium was I always thought it, you'd see elephants going across the wall, something like that. But it's much, much, much more than that.
No, hypoactive ones, the hard ones.
Well, and one of the things that we talked to Lee Fleischer quite a bit and Carol Peden, and some of the things that I've heard them say about the brain health or about brain health is that it's the brain fog too, and we are not really focusing on that so much that someone may come out and they can kind of still do their crossword puzzles and they're okay in normal conversation, but they just feel like they have this horrible brain fog postoperatively. So is that something that you guys are trying to address and looking at different, the levels of delirium and what it looks like?
Well, that's probably a much bigger issue, and I think brain fog can be defined very, very broadly. It can be a day or two after you've had surgery and anesthesia, after you've had a colonoscopy, and you just feel like you need a cup of coffee. You're just not as sharp as you are. So that's really not within the purview of what we want to address that has long-term sequelae. This would be something more that we'd love to eliminate, but that transient brain fog is something that usually doesn't have long-term sequelae. So we've focused in on a very attractive target that can have impact on patients' lives.
I think the brain fog thing, though, the one thing we have been told in frequent conversations is don't be scared to tell people about it.
Yeah, that's exactly what I was going to say.
Just tell them they're not going to be quite right for a few days, and then if they are quite right, it's a bonus. But if they're not quite right, they're reassured.
Yeah, and that they don't understand that as part of a cognitive dysfunction, a post-op cognitive dysfunction, but that it will resolve. But I think it's maybe stepping into the whole world of the conversation with having a conversation about post-op cognitive delirium can look as something as simple as brain fog, and that's going to go away to long-term issues.
Right.
So
let's just check off a few things in the OR. I think we're increasingly learning to avoid things that have anticholinergic activity. Now, it's hard to avoid everything in anesthesia, but there's a sort of available hit list of horror drugs that we should steer away from, and I think we all need to learn those. But what do you think about the triple low story at the moment, which is the sort of depth of anesthesia, blood pressure? Where do you stand on that?
Well, I think, if I could be a little scientific here, I think we need to put that data into context.
Okay.
It's associative data. It's not necessarily causation. I think the triple low there are some things within at least two of those lows that we commonly try to avoid.
Yes.
The other low, the low anesthetic requirement, may actually be a surrogate or an indicator of the patient's mental reserve. So I think those are important parameters that can help identify somebody at higher risk for postoperative delirium, cognitive dysfunction. But the extent to which, if you get one or two of those that is a little bit off, and it's going to be perfectly predictive of postoperative delirium, cognitive dysfunction, in a causation fashion, has yet to be established.
And as I was just looking at a paper we're going to be doing in Journal Club for another one of the papers from the Cleveland Clinic with Dan Sessler and Andrea Kurtz about I just had a quick read of it. As far as I could see, the flag automatically flagging up triple low issues, and two disappointments, it seemed from the paper. One is that most people ignored the information, so they carried on anyway. And those who responded to the information, and I apologise if I've got this slightly wrong, but I'll go into greater detail later on, is those who did respond to it successfully, it didn't seem to make a difference. So the causality is still, the greyness is still there, but we're perhaps everyone would agree with the hypotension one. I think you probably don't want to leave them. And there's some other people have some rule of thumbs about age and MAP there, which is a bit like your 60 and the Versed thing.
Right.
Don't let the MAP go below your age, which is not a bad rule of thumb. I'm getting nervous now as an old man. In the post-operative period, you said that was probably one of the most important areas. Yeah. We haven't heard a lot about that yet. What can we do in that post-op period?
So, again, avoid some medications, such as benzodiazepines. Treat pain very aggressively. Yeah. Patients that are in severe pain can have delirium. Yeah. Help the patient get oriented.
Yes.
So putting back on their glasses, putting on hearing aids as quickly as you can postoperatively. Help them get oriented to their surroundings. So bringing in a family member, somebody they recognize, a spouse, a son or daughter, that helps them get reoriented. And when they may have a moment where they're in delirium, that person can help bring them back. And probably very importantly and underappreciated is good sleep hygiene.
Absolutely.
So when we're in the hospital, particularly the ICU as a patient, and you get woken up every hour or two to take your blood pressure, which is important, or give some medication, deep restorative sleep for long periods of time decreases the incidence of delirium.
It makes a big difference. And we're told repeatedly about the value of using headphones in intensive care, but we never, in our intensive care unit, we never seem to have closed out on that.
Yeah.
Because if you're trying to sleep on a plane, that would be one of your tactics.
Yeah, noise cancelling.
The other thing they introduced very recently was they put a visual, I'm sure you've got these already, a large visual monitor of the sound levels. Such that when you walk in the door, you can see these sound meters, and they go from green to amber to red. And in the first couple of weeks, they're just red the whole time. It's so noisy, the environment.
So noisy.
But you do adapt to it, because you competitively want to get them down. It's been really, really good.
Yeah.
The getting people home as quickly as possible has become a big drive in the UK. Some people say we're just kicking them out quickly, but the old seem to like to get home quickly. They seem to like the familiarity of home. How's it going here?
So that I'm glad you brought that up. I mean, that is critically important. And I think we have moved the needle from being extremely safe, considering that these patients need to be monitoring, to realize that there is some risk to staying in the hospital and being monitored, one of them being delirium and cognitive dysfunction. So getting them home into familiar surroundings, into when they wake up in the middle of the night, this chair is over here, and I'm not going to trip over something and fall and break my hip. But getting them to familiar surroundings, familiar people, and their customs, I think also is critically important.
Very, very. Getting home people in Kentucky, getting them home quickly? Is it playing out?
Yeah, I mean, I think that, one of the things I'm involved with is enhanced recovery programs. I mean, that's really a focus, not kicking them out, sending them home when they're ready, but to get them out of the hospital to reduce, some of these issues and keep them safer,
right.
really. So
great stuff. So Dan, thank you very much indeed for talking to us. Any other takeaway gems? You've been very generous with your time.
I think I really appreciate this time, and I couldn't underscore how important it is as we look to anesthesia. You know, we had a narrative 20 years ago where anesthesia was safe. We had gone from 1 in 5,000 deaths to 1 in 250,000 deaths. And then we've uncovered a new narrative where, as perioperative physicians looking at the episode of care, we can impact things like preventable harm and other diseases. So we're on what I would call the pinnacle, the frontiers of quality and safety right now, and I appreciate your time and attention on the issue of perioperative brain health. And
this was initially an ASA initiative. It still is an AA initiative, but it's a big tent. It's a global hub.
I was just going to ask.
I couldn't underscore that more. So we started this, and you've talked to, I think, Lee Fleischer, the head of this, and we had our first meeting several years ago that involved, I think, over 35 stakeholders. Yes. It was not going to be successful unless we involved a very big tent. The tent is open to anybody, and longitudinally over a long period of time. It could not be just a little flash. But in order to change culture, in order to change practice, it needs to be a sustained initiative. And so this has been a long-standing initiative. As we've gotten into it, I think we've even been more committed as a partner, and we appreciate all the other partners that have come in.
Well, Dan Cole, thank you for your hard work. Thank you for your leadership. Thank you for Southern California.
Yeah.
What a great legacy, the Brain Health Initiative. Everyone, please, if you haven't looked it up already, look it up and do something about it next week.
Yeah, absolutely. Yeah,
thanks everyone for listening.
Dan.
Thank you.
Thank you.
Cheers.
TopMedTalk.
Nate Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.